it's pretty much the same picture. So here, what's this one? Subscapularis, you can see there it's going into part of the rotator cuff. Okay, and then here, what's that process right there? Coracoid, so this muscle would be coracobrachialis. And then this we'll get into later, that's the brachialis, but that's part of the elbow. And then this one here, going from the coracoid process, yeah?
Okay. So is the latissimus dorsi, are those over the external obliques?
Yeah.
But
It's like the external obliques, when you have external intercostals over here, the latissimus kind of starts coming up here, so you don't really have a whole lot of external oblique abdominal muscles starting there yet, but they would. Latissimus is more superficial. Latissimus and trapezius are the more superficial ones, because you have to go under the trapezius to get to the rhomboids and those other ones. But then, because the latissimus is going to attach from the spinous process and the thoracolumbar fascia, which is around the outside, whereas the external intercostals and the external obliques are more tight in against the torso. The torso is like this, and then there are like layers coming around. Because the obliques are going to be coming around like this, whereas the latissimus is heading out towards the humerus. Because it's like if you had an onion, the intercostals and the external obliques would be more the inner skin of the onion, and then the outer skin you could peel out and then heads out this way.
With the injury thing, like the rotator cuff, since there's four muscles there, since some people repair their rotator cuff, is there a muscle, one of the four muscles that's weaker or tends to get more?
Usually, well, when we talked about the subacromial joint or the suprahumeral joint, which is the one that's the, when you get, if you're going up like this and you're impinging, which is the one that's up on the highest spot? Supraspinatus. So that's probably the one that gets injured most. But there's a reason why they call it a rotator cuff. It's not really 1, 2, 3, 4 muscles. It's the muscle bellies kind of all merge together. If you saw one of those pictures, it's like the rotator cuff. It's like you have the joint, you have the joint capsule, which encirculates the whole thing, and then the rotator cuff. Once you get to the tendon part, it's pretty much contiguous all the way around as one big cuff. But then you have different muscles going into to pull it. But usually if you had to pick one that usually gets into more often, it would be the supraspinatus. But it's still a cuff. Okay, so we're down to the insertion is the same place for both the long head and the short head because they come together and they insert down into here, right? And then I'll show you on this because so here's like the radial tuberosity, right? So when the bicep contracts, it pulls it up like this. So if you start in pronation and the muscle's pulling right here, it's going to supinate. So it flexes the shoulder, the elbow, as it's attaching here, so it's pulling up like this, but at the same time it's doing supination because that tuberosity is, if it's down here, so it'll pull it up like that. So the biceps does flexion of the elbow and supination like this because it's pulling that bone around like this. If it's pronated like that, the spot where it attaches pulls it up like that. Right? And that's this, the thing on the bone right here, that's this little tuberosity right here. The bicep's going to do supination. And it doesn't really do that much flexion at the shoulder because the physics of it, you know, this spot is too close to do this. It's better at doing this action than it is at shoulder flexion. And then the triceps, the long head, is going to cross the shoulder joint. And that's going to be at the, if you have a supraglenoid tubercle, you wouldn't have to call it that unless you had a what? Infraglenoid tumor. So this long head of the biceps goes here, long head of the triceps goes here. Right? So it's the infraglenoid tuberosity of the scapula. Then the lateral head is going to be come off of the humerus itself, posterior shaft of the humerus. And then the medial humerus, the medial head just starts down lower. Okay? The short head and the medial head are going to be both off of the humerus. It's just one's more proximal, one's more in the middle. And then they have a common insertion into, what's this? Olecranon. That's going to do extension like that. And then also technically it would do shoulder extension, but not that much. It's more of a it's more action mechanically, it's better suited for elbow extension than it is for shoulder extension. Do you have any questions? I know it's a lot of stuff, but that's all that we have to do for today. Now we're just going to go over it again, and we're going to do palpation, and we're going to talk more about the muscles and stuff. So you're not going to get it the first time, or the second time, or the third time, maybe the fourth time. Because you have to do things, like I said, you have to make your flashcards, and you have to look at different images. Some people are better suited for seeing visual images. Some people are better suited for tactile images and things like that. But whatever it is, the way that you're going to have to do to learn it, that's what you got to do. Okay. I know, it's Friday night. I'm tired. It's okay. But you understand, I mean, when you have a class like this, you have 3 hours a week in class, but there's going to be a lot more hours than you're going to have to study. That's just the way it is. Because the thing is, like I said before, is that this is the basic stuff that you're going to build a lot on in all the other classes and such, as far as point location for landmarks, and then muscle origin insertion, and then you have clinical stuff when you get into orthopedics and neurology and stuff. And then when somebody mentions the whatever tuberosity or the subacromial joint, and you're going to say, oh yeah, I knew that. I remember that. Think. Okay. So we'll take a break.